Andrea's here. Just connecting to audio.
Hello, everybody. So as everybody's filing in from the waiting room, just wanted to let you guys know that this is recorded so that you all will have access to it later on. If you are interested in seeing it yourself or sharing it with people, just send me an email and I will get you the link. And so at this point, I am turning it over to Marge, who will introduce us to this new hypertension bundle.
Hi guys, and thanks for joining. And I just do want to do a couple of quick intros. I think everybody probably knows a lot of us, but you know, Sam Ballinger runs everybody's lives, especially mine, and I greatly appreciate that. Carol McBride, I think a lot of you also know, she is our data queen, and really is the heart of how we collect and report all of our data. And she's going to talk a bit about REDCap. She's your REDCap queen. And I wanted to do a shout out. I see Andrea Carrillo's on. She's our AIM, our local AIM. I don't know what she is, like data, you know, cat herder or whatever, but she keeps us in line, and we just adore her. So I can't tell you how much I appreciate her being on. And now, this is my usual. I'm going to share my screen, and it's going to look funny in a minute because I believe it's the way that that it's going to share when I put it in presentation mode. Do you guys see the correct slide?
Yes, it looks like the correct one.
Not the presentation. Okay, awesome. So thank you. As you guys know, this is our initial kickoff meeting to start the severe hypertension bundle. Yep, I'll move everybody over. And please, Sam will look at the chat, and we'll get to the chat at the end. I promise and if we can't do it, we'll do it by email. But please be interactive that way. I'm going to get through as much as I can so that you can ask any questions. I'm hoping that this one's going to be maybe a little bit easier. I feel like a lot of places are already pretty far ahead on hypertension, but it's still going to be fun. So here's our kickoff of this, and I'm going to do the overview of the bundle. And this is actually, as I was going through, I thought things that we're going to have to drill down in later in the year, because remember, this is just the kickoff. This is not everything you're going to get. We're going to talk a lot about definition, diagnosis, treatment, and I'm going to add in there measurement of blood pressure in hypertension and pregnancy. These are all key features. Then we'll have another one that just talks about protocols, debriefs, drills, and ideally multi-system reviews, because this is another one that I think crosses so many systems, more so in some ways than other ones. And then, of course, I have to bring up our quick drills because we've spent so much time on them, and we're getting ready to mail out the bundles. But that said, please put in the chat if there are specific topics related to hypertension that you're not sure we're going to include on here, or they're an issue for your institution, please put them in there, and I'll make sure that I add them on. So to remind people that AIM is the Alliance for Innovation on Maternal Health. The goal overall is reduction in maternal morbidity and mortality by implementation of very specific safety bundles. And this is linked to longitudinal measurement of outcomes, which are specifically severe maternal morbidity and the implementation of process and structural measures. So you're not going to be able to read this, but I wanted to remind you, anybody can Google the CDC definition of maternal morbidity. There are 21 specific diagnoses with the discharge codes very well defined. You actually don't need to know what these codes are, but I'm going to just remind you, the 21 diagnoses are big, important things that do not happen in our hospitals very often. MI, aneurysm, renal failure, ARDS, amniotic fluid embolism, cardiac events, conversion of cardiac rhythms, DIC, eclampsia, heart failure. So these are not small morbidities. You will see in our data that we don't code these things correctly all the time. We'll just keep working with the different hospitals to do it. But I wanted you to know they are very well defined. And this is the metric, and I'm going to share the data in a minute. So these are the SMM codes that are specific. They're in that little drill down box that are specific to this hypertension one. And it's exactly what you would think. People who have hypertension with superimposed preeclampsia, people who have HELP, people who have eclampsia, these are all major morbidities. So these are data that Carol was nice enough to pull from the discharge data from 2005 to 2018. And she just informed me the reason we don't have updated ones is our numbers are small, so we can't release them to AIM until later. But I just wanted to point out that we can look at these numbers and know that there might be something a little off. For example, we probably don't have 26 cases of eclampsia, even in the whole state, over 3 years. So my guess is there might be some coding issues there. I believe we knew that there was one hospital that was an issue. Same thing with MIs. One of the smaller hospitals coded 11 MIs. Probably not correct. But these are not things that you can do anything about. We can feed back to you. I just wanted to let you know we can find the codes, we identify them, and then we translate them into these 21 diagnoses. And this is how we get up with our total severe maternal morbidity. This would be including people that needed a transfusion. And because transfusion is by far the most common morbidity, it is always important to look at severe maternal morbidity of people who did not require transfusion. So you can take that hemorrhage part out. So this is how we come up with these numbers. And here's just to give you an idea of the number of cases. Here's our 14 MIs. And to give you an idea of what all of these other morbidities look like relative to our transfusion morbidity this is normal. This is what every state looks like. It's just a reflection of, as William says, obstetrics is bloody business, and it is. So this is what it looks like though, just so you know, when you don't, without the transfusion data. So you can just get an idea of the granularity of the data. The other piece here is you can see that while DIC is generally related to hemorrhage, after that, the eclampsia, and I would say just preeclampsia, even though this is overcoded, and renal failure are probably, and my guess is pulmonary edema from our institution, those are probably going to be the three main morbidities we're going to see related to hypertension. Now, these data did come off the AIM website. Thank you, guys. So this is from 2020. This is our overall severe maternal morbidity, and this does not include transfusion. And this shows you the data by the number of births in each hospital. And I just like to point out, I wonder who that is, that it does vary, and we do have a bit of variation in these numbers. Now, I want to remind people that whenever we're talking about very small numbers, a difference of one patient could mean the difference between this, and this. So the actual ends are also really important. I did want to give you these data because remember, we've wrapped up our postpartum hemorrhage bundle. And for 2020, again, this is excluding transfusions. I guess I could have probably used the graph that included transfusions for that one, but I just wanted to give you an idea. This is our overall morbidity, but if we only look at people that had hemorrhage, there's still, you can still see that there are hospitals that have more or less morbidity associated with postpartum hemorrhage. So these are data that we can get from AIM. And Carol tells me that as soon as we have more Ns, we'll be able to get them by diagnosis. And this is one of our first, AIM rollouts. So this is just good data to see. This also came from AIM, and in my opinion, this is one of the most impactful issues of AIM, which is that we can benchmark nationally. And I can even benchmark by size. There are a bunch of graphs, but I only discovered it like an hour before this talk, so I only could pull off a few slides and really integrate them. And we'll present that to this group at some point. But basically, this is our Vermont data, and the red are our national data. And these are just the SMM numbers by collaborative. And you can see, I have to say, this is years after our collaborative kickoff. Our kickoff, obviously, these are data from, I can't hover and see. But the bottom line is you can see that there is some variation, but compared to the country, the point of this slide is to be like, we actually do pretty well, which we've always sort of known, but a difference of one patient can make a big change. So now back to the bundle, which is really what we're going to talk about today, which is remember the 5 R's of AIM: readiness, recognition, response for every event, reporting and systems, and then this you'll see now integrated into every bundle: respectful, equitable, and supportive care. And it used to sort of live outside the bundles, but now I'm really glad to hear that they're integrated in it. And for the hypertension bundle in particular, it's important because when we think about issues of maternal mortality and severe morbidity, especially in terms of stroke, this is one of the main reasons that there are disparities in maternal mortality across this country. Black women especially are prone to severe hypertensive events. So for this bundle, the issue of equity and access is especially important. I want to add that in Vermont, we initially had some difficulty getting data by race. Carol did her magic, and we will be seeing that soon.
Marge, can I just interrupt? Those data are available on the AIM website. We have to lump together years because our numbers are so small outside of Chittenden County, of course. But on the AIM website, you can look at rates of severe maternal morbidity by race and ethnicity, and also by percent Medicaid of your population, which is another interesting way to look at the data.
Yeah, I'm beginning to think, Sam, we should probably just add an extra webinar, pretty much just going through all the AIM data. Thanks. So basically, the next few slides have a lot of words on them, and I'm just basically rolling you into these 5 R's very slowly. We're going to break all of these down in subsequent slides. But basically, for readiness, it's a matter of developing standardized processes for women with severe hypertension, which I suspect you guys already know. And in terms of a standard protocol for early warning signs, diagnostic criteria, and monitoring, we have a lot of support and educational materials for that. Timely triage and evaluation, that really goes in general into a policy. We're going to talk about that. And a systematic plan for escalation and consultation, which I know a lot of you guys already have. Part of the readiness is to make sure you have rapid access to medications. I know a lot of you guys are already there with your hypertensive kits. We're going to talk about that. We're talking about drills. As you know, we've talked about quick drills already, and debriefs, which are super important. Develop and maintain a set of referral resources and communication pathways. And I feel like we do very well with the obstetric providers. But again, for this hypertension bundle specifically, I feel like we really are going to have to double down on our family medicine colleagues and our EDs, where postpartum women may present and where In RED, a blood pressure of 160 over 110 does not even raise an eyebrow. So we already had to do work with our ED to get them to call us for some of these things. And I suspect we're not alone. And of course, trauma-informed protocols and education to enhance equitable care. In terms of recognition and prevention, to assess and document if they're pregnant. And I will add, Andrea, I was going to email you and ask Amy about this, about people that are pregnant in the last year. I can understand that from a mortality standpoint. I think that for a hypertensive morbidity standpoint and for an AD triage, that's a little bit, I just want to talk about that because we don't, if somebody comes in hypertensive a year after a delivery, I don't know the OB is the team that should be called, but be that as it may, I think clearly in the postpartum period, people need to know. Ensure accurate and measurement and assessment of blood pressures for everybody. And I think that we've already had some things about how to take a blood pressure. That's really important. Screen for structural and social drivers of healthcare that could impact the clinical recommendations. I will tell you, we are doing a lot of work, especially in terms of language access. I believe that that should be a focus of our group moving forward. That would be another one to talk about specifically, and to make sure all the documents are in the right languages or you have access to them in different languages. Ongoing care for people who have symptoms of hypertension and preeclampsia, and education to all healthcare team measures. And this one also has to include not just OB providers and not just anesthesiology, but especially the ET and family medicine, people where people might show up for hypertension. And then in terms of the responses, to utilize a standardized protocol with checklists and escalation policies with a standard response to maternal early warning signs and symptoms, to initiate postpartum follow-up within 3 days of hospital discharge with severe hypertensive disorders, and of course, trauma-informed care. And now when we talk about reporting, remember, this is what covers the issue of multidisciplinary planning, huddles, and debriefs for every severe hypertensive episode. And again, in your hospitals, it's not going to be that often. All the more reason to make sure you debrief every single time and to do multidisciplinary reviews. And this is one of our more frequent ones, honestly, with the emergency room. And then, of course, monitoring the outcome data, which we just talked about. And this is the respectful, equitable, and supportive care. And just before this talk, Carol and I were talking because we've been talking a lot about that here in this institution. And I think it might be like a year before this group will be able to see whatever our results are. But I want you to know that we are digging down very, very specifically about issues of equitable care. I know that each community now has more people that are coming from other countries, language access, understanding how medicine is delivered. These are all challenges that we all have to start thinking about so that people can get the kind of care we all want to provide. So I just want you to know that this is becoming nearer and dearer to our hearts, and we are working on this. So definitions. It would be nice to have a conversation with your coders about how they decide what the diagnosis is a patient has. I know for our institution, we are terrible about putting problems appropriately on the problem list. Every single person comes in, they could have come in having a seizure and an MI outside, and it would be normal supervision of pregnancy with their admission diagnosis. So the coders go through and will look at our notes to extract the diagnoses. I would not be surprised if many of you it's the same. And so I would just encourage you to be as careful as you can about the definition of the hypertensive disease that you're admitting a patient with. That will actually help your coders the most, because otherwise they may be trying to just guess. So I'm not going to ask you to necessarily update the problem list, because while I would like that, I can't imagine that we're going to do that reliably even here all the time. If you put the right diagnosis in your notes, the coders will pick up on that. I believe these are definitions you all know. I don't feel like I have to go through them. We will go through them in detail when we do the diagnosis. Again, the most important thing is to take the blood pressure correctly and with the right size cuff. But we will talk about this more, but I wanted to remind you about these diagnoses and the importance of using the correct one for your coders. So now, now onto the weedy parts. So readiness, and this is in every care setting, and this would include the emergency room, urgent care. I'm not as worried about critical care. Everybody is pretty much all on top of those. I even think the OBGYN offices are good, but I think it's these other outside people that people might get a blood pressure at. So we definitely need to make sure that in every institution, the people in these spheres are included in the rollout. Medications. Again, as we work through the rollout, to remind you that everybody should have an emergency hypertension kit on their floor that has meds. We all know calling down to the pharmacy to get emergency meds is very difficult. I say that, but like, I don't have mag on the floor. We have to wait till it comes up. But I think especially for treatment of emergency hypertension, nifedipine, hydralazine, will be along. Drills and simulations, we've talked about quick drills already. And the reason that this is especially important for hypertension is because of the time element. You'll see throughout this rollout that from the time that a sustained blood pressure, that's for 15 minutes, is diagnosed, we are going to be measuring how often they've received medications within an hour. And that, as you guys all know, the number of steps that have to happen to make that work. And we'll work through this, but I think drilling and simulations are going to be especially important with your kit, of course. Oh, I forgot to fix this. But to make sure that referral and resources, I feel like in general, most people do pretty well with the referrals. Actually, I have a transport conference later today that somebody probably could have sent somebody a little earlier. But to make sure that those are in place, I feel confident that we have those, but it is something that we'll review. And of course, this issue of trauma-informed care and training, and this is going to be an ongoing issue, especially for marginalized communities. In terms of recognition and prevention, obviously pretty straightforward. You guys all know about preclinical labs. Make sure you work with your lab to have a panel, or make sure your nurses know how to make favorites. In terms of screening, I think that this is going to be the most important thing, is that people can get the postpartum follow-up. We're definitely seeing an uptick in postpartum hypertension. I don't know if it's just because we're looking for it more. But actually, of all the things that require some coordination, this is probably the most. And certainly patient education. And we've already got those protocols in place, as you know, from the discharge materials that we've already talked about from hemorrhage, include emergency hypertension. So response. Everybody should have a good guideline in terms of how to take a blood pressure, what the blood pressure parameters are, the treatment algorithms, how to administer MAG, what to do if you have MAG toxicity, and what do you do if somebody seizes. We have a guideline for us. We don't call it a policy because, as most things, there's always some clinical element that might require adjustment. We're happy to share ours, and you can steal whatever is helpful or not. I think this is probably one of the more important ones, is this postpartum follow-up, and we'll talk about that later. We are going to be measuring then number of women that have a plan for postpartum follow-up blood pressure 3 days within discharge of a severe event. Now, throughout the documents in general, this says 3 days. I will tell you later in the document, it says if it's severe, it should be 3 days. And if it's not severe, or you just have hypertension, it can be 7. I think 3 days is probably not a bad one if you just want to pick one number for everybody. I would encourage you, of all the things that you might want to leave today with and alter in what you do every day, is to make sure you do a blood pressure check 3 days after discharge from a patient, with a patient that has any type of hypertension, because it may well get worse. So that's something everybody can implement now. I would strongly encourage. Trauma-informed care, of course, in terms of how to get follow-up, very important. In terms of translators, transportation, how do you do the postpartum follow-up? We're going to talk about that in a minute. Multidisciplinary reviews, this is on every bundle, very important. And I will add, we haven't talked that much about it. And as I talk to each individual hospital, I would like to get more information. Most of you guys feel that you have a pretty good system, but that might be something to talk about in the future. And then, of course, respectful and equitable and supportive care. And of all of these things, which we need to know, I will task you with one more thing to start looking into right away, which is language and translator access. Every hospital should have them. Ours are not even great. They honestly, like in our clinic, they give us these phones. I said, I'm going to bring these phones home and I'm going to just take a hammer to them myself because you can't hear anything on them. So language access is really hard. So we can talk about that, and I'm curious to hear from you guys how much support you need with getting decent translator access or materials in the right language. We may be able to help with that. And I just want you to tag that is one of the biggest barriers that I think exists. So now how do we measure? These should be pretty familiar to you guys. We look at the outcomes that I showed you. We look at process measures and we look at structural measures. And thank you for filling out the red cap form. So the outcomes that we're going to look at, this is not anything new. We are going to extract these codes. When I say we, I mean Carol will be pulling the access codes from the discharge data. This we will have to pull out of the EMRs, and some of you guys might need to do it manually. That's the bad news. The good news is you probably don't have that many people that have severe persistent hypertension, because we really want to know the number of people that have a severe hypertensive episode and the number of people that got treated within an hour. And we'll, as we did last time when we talked to every single hospital, I'm happy to support in whatever way to how to problem solve this. My guess is you're going to need to just keep a list of people who have persistent severe hypertension and do a chart review. This is the other thing that's really important, the scheduling of postpartum blood pressure checks. This is where they differentiated between severe at 3 days and really any hypertensive disease that's not severe within 7. The point being that you should have a plan documented in the chart, in the discharge record of how they're going to get their blood pressure checked. And we have really started to give blood pressure cuffs to everybody so that they can check them at home. It's been super helpful. And actually, we're doing it during pregnancy. So if anybody develops any hypertension during pregnancy, just get them a cuff and then they'll have it at home. The OB provider education, this should be familiar to you. They need to be every 2 years. I know a lot of you guys do it differently. We do have a cornerstone module that as soon as I see the final version, I'll share with you. We're going to be uploading it within the next month or so. And we also have a mandatory DEI on diversity, equity, and inclusion. And if your hospitals, they should have one. If they don't, I'm happy to share that as well. To just jumpstart people on their education. And of course, this is not just for providers, it's also for nurses. But the most important thing here, again, I can't emphasize it enough, is the ED provider. This has been a change for us. It took us only like 6 months to even get the question, have you been pregnant in the last 6 weeks, onto the triage docket for the ED. And I think it's not even going to be implemented for maybe another month. This is not an easy thing for EDs to do, to remember. They're super busy. So it's going to take some work with your ED providers, but this is really critically important. And of course, the drills we already talked about, the in situ drills and any drills on the unit. And we are always happy to help facilitate that. Debriefs. These are just the structural measures. Again, these also probably look very familiar to you about whether we have a standardized process to conduct debriefs, whether or not you have debriefs, whether you have case reviews, and whether or not you have unit policies and procedures. And we have guidelines and things that we can share that you can largely take and modify for your institution for that. The patient education piece, I think it's very similar to the hypertension. We need to have the correct languages, the materials in a number of languages. Check with us if you have difficulty with that. And yeah, this is my reminder to ask you if you want a webinar on that. And again, very important from the emergency room follow-up. I added this at the request of Katie Leffler, who's the head of our visiting nurse, who works closely with our state visiting nurse association, to remind everybody that our VNA nurses are awesome and want to help. And so remember those blood pressures that might be really hard to do? The VNA can help do that. And we can really utilize the VNA to help bridge the inpatient and the outpatient care. Right, moms, they're here, they got new babies. It's going to be hard for them to be completely compliant for everything. The VNA can help reassure them with the baby. They can check their blood pressure, make sure everybody's fine. We will be, and there might even be some today, of the VNA on these webinars, and we are going to include trying to keep them on our team. I would encourage you guys as individual hospitals, you know who your VNA nurses are, to please make sure that you include them with the rollout, really, of all the AIM bundles. And I think that's super, and that's going to be really important. You know, we are still, the issue of patient support after severe hypertension. I think, in general, this is who has discussions about verbal debriefing, and we can, again, talk about that later. I think the most important thing is emphasizing the importance of good blood pressure control and follow-up. And remember, anybody who has hypertension during pregnancy has a risk, a lifetime of cardiovascular events later in life. That is very, very well documented. So I think that it would be nice to think about a standard phrase, and we can put that in one of the webinars to tell everybody that has any hypertension in pregnancy about their need to follow for hypertensive disease later. So now I'm going to turn it over to Carol.
Okay, Marge, could you actually go to the next slide first? So we'll talk about this first before I hijack the screen sharing. Whoop, back one, please. So everyone, or each nurse manager at the hospitals already participates in data collection through data collection forms for a variety of different clinical situations on both maternal and neonatal outcomes. So this is a screenshot of one one of the forms that pertains to maternal hypertension. So everyone should be familiar with this, or at least everyone who already fills it out should be familiar with it. But this is where we ask for just a count of within your hospital, pregnant people who are diagnosed with gestational hypertension, preeclampsia, eclampsia, or superimposed preeclampsia on chronic hypertension. And we've been collecting these data now for 2 years. This went in at the same time as the hemorrhage rollout, because we knew that this was going to be our next data, or our next bundle. So this has not changed. We're going to continue to collect the data in this form, the section 2 of that red cap page. We're going to use this as a data validation tool with our new methods and to back up the structural and process measures that we're going to be collecting. So I'm going to hijack the screen for a second. Okay. So some important key points, because there have been some changes to AIM data collection since the hemorrhage rollout 2 years ago. Marge talked about how we used to report both with and without blood transfusions. We now no longer report to AIM just blood transfusions as a severe maternal morbidity. So we only look at all of those other severe situations that can occur with blood transfusion. But if a pregnant person only has a blood transfusion, they no longer count as a severe maternal morbidity. So that changes what we're reporting in some ways. And secondly, when I run all those codes for all the different ICD-10 codes for severe maternal morbidities, we actually don't report the specific diagnoses to AIM. We look at those internally just to make sure that coding errors aren't occurring, like with the massive number of people with eclampsia. That lets us know, oh, that's probably a coding error, and we can go back to the hospital. Those numbers, because they're so small and because it's severe maternal morbidity is a conglomeration of all of those codes, we report the rate of all severe maternal morbidities, but we do have those individual diagnoses internally. Other things that are changing, this is a very simplified form that I think went out to everyone or will be going out, that just talks about how we're no longer counting those blood transfusions, and then how the inclusion of postpartum blood pressure and symptoms checks is new to people who have been doing the hypertension bundle in the past. But it's actually really convenient for us that they've made these changes right before we're doing this rollout. So we can incorporate it as if it has always been a part of the bundle, even though for anyone who's been working on this before, they're having to change what they're doing. So I'm gonna move to this form. Marge went over all of the different process and structural measures and what they each mean. So what we're doing to collect data specifically from the hospitals is sending out a red cap survey. And we are doing this in a little bit different way from the hemorrhage bundle. For that, we were looking for quarterly data, and it wound up being a little bit cumbersome because you're sending things out and some people reply and some people don't. So the dates get a little bit wonky. So we're going to implement this on a monthly request. So every month it'll go out. Once we roll over those new data collection forms that everyone is used to, it will be part of that monthly survey, because then all of our requests will go out at once. So you're not getting multiple emails from multiple people at different times. It'll just be one ask. And hopefully that will streamline things. We also want to just mention that this bundle data collection is going to be a little bit complex. The process and structural measures, just because of the nature of the type of data, where you're not looking specifically for numbers of cases, you're having to look in all of these different places to get numbers. It's very possible that one person at your hospital is not the correct person to fill out the entire thing. You're going to need data from the ED. You're going to need data probably from the quality team. So we're going to send this out, and we want everyone to look it over. Let us know if there are any questions. And then on the first go round, just try to identify, like, who are the people who probably have these data? And then what can we do to support getting these data in a way that will be more streamlined, so that every month you're not hunting down people and trying to find the numbers. ultimately, this data collection is also quality improvement. So we're trying to streamline the way in which we can get these numbers and the way in which your hospital talks between departments. So just remember, whenever you're like, I don't know where to get this is also quality improvement, and we will probably make some changes to make this a little bit smoother as we go forward. So I don't want to take a ton of time because we don't have a lot of time, but this is taken word for word from those process and structural measures that Marge presented. So each one has a header. I'll just go through quickly. So you have the denominator of each, the numerator of each, and then this is grayed out for you because it's calculated percentage. So once you put in those other values, it will pop up with the percentage in your hospital of the patients that are being that are meeting that metric. So for this timely treatment of persistent severe hypertension. We'll probably also need to find a way to get data from VNA if they're doing the postpartum visits. That's going to be a separate discussion with the Department of Health and Katie Leffel and with each hospital, because ultimately each hospital is going to have their own procedures and policies for how to handle these postpartum checks. But with this data collection form, it's a great reminder that we do need to collect these data and we do need to make sure that we're monitoring our patients postpartum. So again, for each survey, there's a question on what is the denominator of the question, what is the numerator of the question, and it'll spit out a percentage of whatever that specific topic was. So for this, the number of pregnant and postpartum people during the birth admission with acute onset severe hypertension.
And I just want to point out that the metric is actually the people that are scheduled, recognizing that it might be hard to know if it actually happened. That's why it's so important to have in your discharge paperwork when they're scheduled to come back for a blood pressure check.
Yes. And it can also be complex because sometimes you have people who are transferred in from a different institution. They may be seeing private practitioners for their prenatal and postpartum care. So you only actually see them for their delivery admission. So all of those pieces make data collection very complex, and we acknowledge that. We know that that's a limitation, and we know it might be hard to get around those things, but that's something we ask you to kind of think over, like, how can we get those data from the private practitioners? They should be a part of this conversation as well because they are providing care. So again, those go through the process measures. Provider education, this is the same as we've seen before, provider and nursing education. We saw those with the hemorrhage bundle. What is new, Marge talked about this, is the ED provider and nursing education. It's very important that we really get our ED providers involved in this bundle because they do often see postpartum hypertension show up in the ED and very rarely ask, hey, have you been pregnant or delivered? And just getting them to ask is going to be a much bigger lift than it should be. So making sure that they're educated to even just ask that question. Have you been pregnant? Are you pregnant? They're key questions. One thing that has changed with unit drills, we ask about the number, and now we have check boxes. So you can say, we did a hypertension bundle, a hemorrhage bundle, a severe hypertension bundle, or other. So you don't have to go back to your notes and find out what else you did. Hopefully you can remember if you did one of those two or if you did something else. Then the structural measures, we used to ask you to come up with a number of where you were, like a very arbitrary number of where you were in the process of implementing each of these structural measures. Now there's a nice little slider bar. So either you can say not started, completed, or leave it somewhere in the middle. Again, it's still pretty arbitrary, but we want to see process. Don't feel bad if you haven't started any of these yet. We're just rolling out the bundle now. So if everybody on everything is at not started, that actually gives us a lot of room for improvement over the next 2 years of this bundle rollout. So always answer honestly so that we can see, we expect that everyone will have some improvements, some setbacks, different questions, different structural measures may be really easy to accomplish. Others might be harder. So you might always wind up in that in-process range. It is a there are 5 different bounds of where in that slider you can choose. So there are actually 3 different levels of in process, and then the not started and completed. And then these each go through the different structural measures that Marge talked about. There are a number of them about education and even the ED and your policies and your ways of approaching things like what I'm blanking out on the term, but case reviews and debriefs. And then we just ask so that we know who filled out the form, so that we can, if we have any questions, we can reach you and ask what those questions are. And then when was the form filled out, so that we know the appropriate time range when we were collecting the data. So it's pretty straightforward. We do expect there will be questions once this goes out to you. And again, this data collection tool is a quality improvement metric of its own, and we expect to have to make changes based on your feedback. So please look through it, make a test case, and kind of go through and see how it feels to each of you, and give us feedback, and we will make those changes so that it is as easy and streamlined to work with as possible. Okay, Marge, you can take the screen back. Or Sam, do you have it?
Great, can you guys see that?
Yep.
Great, so just to remind you, I just have a couple of more slides and then we can open up to any questions. We rolled this out with the hypertension bundle. This is just the A1 document, which I've heard through the grapevine that people thought it was too wordy. So they're in the process of revising it, but this is the one that we give everybody. I am embarrassed to tell you, I don't even know if we have this in other languages. I do know we have some translator ability, but I will tell you it's on my short list to double check that. But we have this documentation for post-birth warning signs specific to hemorrhage and hypertension. And I wanted you to know that we have a document that apparently is expired, at least my copy is, for hypertension, and we're happy to share that with anybody if you just want to see how a policy is and a guideline is set up. And this just has all the weedy stuff that guidelines have about what to do when. You guys are going to be getting this soon from Sam. She's been working on it for a year. This is when we did our drill issues, we finally have the resource binders all printed up, collated. We're just putting the finest finishing touches on it. And I wanted to remind you that this resource binder goes with our quick drills, but actually has every piece of information that you need about hypertension in it. And not only that, but it has where we got the information from. Some of them are internal policies, some of them we took from Up to Date, some of them from CMQCC. So that people know as things get updated where they came from. But these drill binders are great for the drills, but I wanted you to know that this resource binder also has pretty much everything you need for hypertension and hemorrhage in it. So I think that I'm hoping that we can implement this over a year. Again, these are the topics. Let me know if there are other ones that you want, or if there are specific tools that you want developed that are not reflected in the stuff that we're going to send you. And again, yeah, a little typo, but I wanted to make sure that everybody really had the VNA on the radar to make sure we don't have in the resource binder supporting documents, but we'll create for the VNA Also some supporting documents, including standards for follow-up for blood pressure checks. And I'm going to tell you the short story is that they're going to be instructed to call your office if blood pressure is 140/90 or greater. And in general, that's when we would initiate postpartum medications, but we can talk about that with the later webinars. But so I will develop some specific some VNA specific documentations. So that is actually all that I have, and I'm happy to open it up. We only have a few minutes, but I'm happy to open it up to anybody. You can put questions in the chat. You can raise your hand, and or as you know, you can always email me or Sam. I know you guys do a lot, which I really appreciate. If you have a question or you need something, then just let us know.
Are there any questions? I don't see anything in the chat yet.
Well, thanks, because it is getting to be time, but I will, Sam doesn't know this yet because we seem to be always scheduling visits with all the hospitals, but I really like to touch base with each hospital about each one. So I think, Sam, what do you think? We'll start them in the spring. Just schedule, we'll be attending the nurse managers meeting as a group, as we always do, but I do like to talk to each individual hospital because everybody's got their own stuff, but let us know if you need anything in the meantime. Thanks.
All right, thank you, everybody. And just a reminder that this has been recorded. So if you would like a copy of the recording, you can email me. I believe you can still access it even using this link. So thank you, everybody, for attending.